Good day. I will be discussing the second part of valvular heart disease, which covers the aortic, tricuspid, and pulmonic valves. First is the aortic valve stenosis. This occurs when the heart's aortic valve narrows. This narrowing prevents the valve from opening fully, which reduces or blocks blood flow from your heart into the main artery to your body, which is the aorta, and onwards to the rest of your body. This occurs about a quarter of all patients with valvular heart disease. Approximately 80% are male and symptomatic individuals. This is the aortic valve. Normally has three cusps or leaflets, although in 1 to 2% of the population it is found to be congenital, and congenital patients have two leaflets. The aortic valve, like pulmonic valve, normally has three cusps or leaflets and commissures. In contrast to the mitral and tricuspid valves, the two semilunar valves have no tensor apparatus like the chordae tendineae and papillary muscles. The commissures form tall peak spaces between the attachments of adjacent cusps. As you can see, the ostia of the left and right coronary arteries are located just above the aortic valve, as are the left and the right sinuses of Valsalva. The function is oxygenated blood is pumped into the aorta from the left ventricle. It then flows into the coronary ostia, where the blood flow into the coronary arteries is greatest during the ventricular diastole. These are the following etiologies of aortic stenosis. First is the bicuspid aortic valve. This is the most common congenital heart valve defect with 0.5 to 1.4% incidence. This is associated with mutation of NATCH1 gene. This is during systole and during the diastole, with sometimes visible rock. Sometimes they manifest with the systolic doming motion on echocardiography. This is just a schematic representation of a normal tricuspid valve in comparison to variants of bicuspid valve. Frequently, the bicuspid valve is associated with coarctation of aorta and aortic aneurysm. So, patients with this disease have larger aortas comparable with the tricuspid aortic valve disease. This aortopathy develops independent of hemodynamic severity. Another example of etiology of a congenital unicuspid valve. You can see that there's only one point of attachment at the 6 o'clock position with a funnel-shaped valve opening. Next is the regenerative calcific aortic stenosis. This is characterized by a fibrocalcific masses on the aortic side of the leaflet that result in increased leaflet stiffness without commissural fusion. Calcific shadowing and reverberations limit image quality. The aortic stenosis in adult is usually due to degenerative calcification of aortic cusp and most commonly as a substrate of congenital bicuspid aortic valve, chronic tri-leaflet deterioration, and a previous rheumatic infection. This is a schematic working model of the interplay between the risk factors for fibrocalcific aortic valve disease and dysfunctional response to injury that can increase propensity for the development of valvular stenosis. Note that both valvular calcification and fibrosis are likely to play major roles in the development of hemodynamically significant aortic valve dysfunction. Genetic polymorphisms, including the vitamin D receptor, estrogen receptor, and postmenopausal women, interleukin 10, apolipoprotein E4 have been linked to the development of calcific AS. Several traditional risk factors have also been associated with development of AS, including LDL, lipoprotein A, diabetes, smoking, CKD, and metabolic syndrome. Next etiology is the rheumatic fever. The diagnostic features includes commissural fusion and mitral valve involvement with characteristic triangular aortic valve opening in systole. The commissures are fused, and this becomes susceptible to trauma, fibrosis, calcification, and further narrowing. The rheumatic AS is almost always associated with involvement of the mitral valve and with aortic regurgitation. As you can see in this example, this patient has a mitral stenosis, same time has a aortic stenosis. In time, patient have a moderate aortic stenosis, but if there is involvement of all commissures, sometimes they also develop concomitant insufficiency or regurgitation. Another etiology is the radiation-induced aortic stenosis, where high-dose radiation to the chest induces severe fibrosis and calcification of the aortic and the mitral valves. A characteristic finding is heavy calcification along the aortomitral curtain. These are in addition to valvular aortic stenosis, 3 other lesions may be responsible for obstruction to left ventricular outflow. This includes the hypertrophic obstructive cardiomyopathy, wherein there is a thickened interventricular septum obstructing the flow from LV to the aorta. This is on echo you will see a thickened septum and a turbulent flow at the left ventricular outflow tract. This one is a discrete fibromuscular subaortic stenosis that's just below the aortic valve. This is how it looks like on 2D echo. The presence of subaortic stenosis and presence of a turbulent flow at the left ventricular outflow tract. An example of a supravalvular aortic stenosis, and this is how it looks like on 2D echo. Okay. The obstruction of LV outflow produces a systolic pressure gradient between the LV and the aorta, as you can see in the hemodynamic tracing. So this is the aortic pressure, and this one is for the left ventricular pressure. So this is the gradient between the chamber. The severe obstruction in acute onset responds by LV dilation and reduction of stroke volume. For patients with a chronic severe obstruction, the LV contractile performance is maintained by presence of concentric left ventricular hypertrophy. A large trans-aortic valve pressure gradient may exist for many years without a reduction in cardiac output or LV dilation. This excessive hypertrophy becomes maladaptive and may lead to left ventricular failure. Severe obstruction to LV outflow is described as a mean systolic pressure gradient of more than 40 millimeters mercury, or effective aortic orifice area of less than 1 centimeter square or less than 0.6 centimeter squared for a body surface area. This is how it is computed based on the gradient at the left ventricular outflow tract area and just at the transvalvular area. So the diminished compliance of the hypertrophic left ventricle is described as elevated left and diastolic pressure, and this can be determined by the pulmonary capillary wedge pressure. So late in the course, patient may develop fibrosis, so the contractile function deteriorates because of a afterload excess. The LV performance can be further compromised by a superimposed coronary artery disease. The three cardinal symptoms are the exertional dyspnea, angina pectoris, and syncope. Exertional dyspnea is due to elevated pulmonary capillary wedge pressure caused by elevation of left ventricular and diastolic pressure. Angina pectoris is imbalance between the augmented myocardial oxygen requirements secondary to thick left ventricular anatomy. Syncope is defined as decline in arterial pressure caused by vasodilation and exercising muscles and inadequate vasoconstriction. Sudden fall in cardiac output produced by an arrhythmia. For advanced stages, the patient may have a marked fatigability, weakness, peripheral cyanosis, cachexia, orthopnea, paroxysmal nocturnal dyspnea, and pulmonary edema, likely related to pulmonary pathophysiology. For patients with a severe pulmonary hypertension, they can develop a hepatomegaly, and patient with the left atrial enlargement, patient can develop a atrial fibrillation. Rhythm is generally regular. If there is atrial fibrillation, this suggests a possibility of involvement of mitral valve. In late stages, the stroke volume declines, the systolic pressure may fall, and the pulse pressures narrow. So what we call the pulsus parvus et tardus, wherein there is a slow and delayed peak of the pulse. A wave in the jugular venous pulse is also accentuated because of the diminished distensibility of the right ventricular cavity. LV impulse is usually displaced laterally. Sometimes you will be able to appreciate a double apical impulse, but particularly in a left lateral recumbent position. Systolic trill may be present at the base of the heart to the right of the sternum when leaning forward. These are the auscultation findings in patients with the aortic stenosis. Early ejection sound in patient or young, in a patient with a congenital bicuspid aortic valve. Paradoxical splitting is also common. This is described as a splitting on expiration instead of inspiration. This is compared with a patient with normal physiologic splitting during inspiration. The sound of aortic valve closure can be heard most frequently in patients with aortic stenosis who have pliable valves, and calcification diminishes the intensity of this sound. S4 is audible at the apex and reflects the presence of LVH and elevated left ventricular and diastolic pressure. The S3 generally occurs late in the course when the left ventricular dilates and its systolic functions become severely compromised. The ejection murmur commences shortly after the first heart sound. This increases in intensity to reach a peak towards the middle of ejection, ends just before aortic valve closure. These are low pitch, rough, and rasping in character. These are loudest at the base of the heart at the second right intercostal space. They are transmitted upward along the carotid arteries and and occasionally transmitted downward into the apex where it may be confused with the systolic murmur of mitral regurgitation, which we call Galabardine effect. For the ECG, there can be an evidence of left ventricular hypertrophy with a strain pattern. This is the criteria for left ventricular hypertrophy, and commonly used is the Sokolow-Lyon criteria, where you get the S of the B1 and the R of the B5 or B6. If it is more than 3.5 millivolts, that is suggestive of left ventricular hypertrophy. For this example, you check for S of B1 and the R of B5 or B6. Okay, so it satisfies the criteria for left ventricular hypertrophy. For chest X-ray, there is a rounding of cardiac apex with a dilated proximal ascending aorta. It can be an LV enlargement on PA right heart chambers. Sometimes you can be able to appreciate a aortic valve calcification. On echo, you can appreciate presence of thickening, calcification, and reduced opening of the valve leaflets. As you can see, during systole, there is no opening of the aortic valve. So this is an example of aortic stenosis showing a thickened valve leaflets and a commissural fusion. Example in a patient with a degenerative calcification. For patients with a bicuspid aortic valve, they are described as with the eccentric closure of aortic valve cusp. An example of a color Doppler flow in patient with a aortic stenosis was from LV going to the aorta. There is a turbulent flow across the aortic valve, and this is measured to determine the peak velocity. So we can compute the aortic valve area based on the mean gradient at the diameter of LVOT area and the mean gradient at the transvalvular area. Okay, another example of determining the severity of aortic stenosis. So for severe AS, they are described as valve area of less than 1 centimeter squared, moderate AS at 1 to 1.5, mild AS 1.5 to 2 centimeters squared. For patients with only aortic valve sclerosis, the jet velocity should be less than 2.5 meters per second or a peak gradient less than 25 millimeters mercury. Dobutamine stress echo is useful for evaluation in patients with aortic stenosis and at the same time with decreased ejection fraction. Cardiac catheterization is used for patients with multivalvular heart disease, young asymptomatic patients with non-calcific congenital IEAS, and in patients whom obstructions is at the subaortic or the supravalvular area. This is the trans-aortic pressure gradient, wherein there is a gradient between the left ventricle, the blue tracing, and the aorta, the red tracing. Death in patients with severe AS most common in 7th and 8th decade. The average time to death after the onset of various symptoms was as follows: 3 years for patients with angina pectoris and syncope, 2 years for dyspnea, and 1.5 to 2 years for patients with congestive heart failure. Sudden death as the first manifestation of severe AS is very uncommon. Calcific AS is a progressive disease with annual reduction in valve area averaging of 0.1 centimeter squared and an annual increase of jet velocity of 0.3 millimeters per second. Treatment includes avoid strenuous physical activity, avoiding dehydration and hypovolemia, and you can also start beta blockers, ACE inhibitors, and statins with patients with concomitant hypertension and coronary artery disease. Surgery is indicated if the patient has a severe AS described as a valve area of less than 1 centimeter squared or less than 0.6 centimeter squared indexed to the body surface area. Also in patients with our symptomatic LV dysfunction, bicuspid aortic valve with more than 4.5 centimeter maximal dimension, or increase in size of more than 0.5 centimeter per year. This can be also done in patients with asymptomatic AS who are referred for bypass. So it should be done at the same time with the aortic valve replacement. Another procedure is the percutaneous balloon aortic valvuloplasty, which is preferable in patients who are young and non-calcific AS. It is not commonly used in patients with severe calcific aortic stenosis and can also be used only as a bridge to operation. This is the summary of treatment for patients with aortic stenosis. So patients can undergo aortic valve replacement in patients who are symptomatic with decreased EF and large diameter and large ventricular diameter. So this is how it's done for patients with aortic valve replacement. Perioperative mortality in patients with isolated aortic valve replacement is about 2%, but can be as high as 4% for patients with the same time coronary artery bypass, or 8% for associated mitral valve replacement. We can further identify if patient is of a low risk, high risk, and prohibitive risk. For patients with the prohibitive, high, and intermediate surgical risk, we can do the trans-aortic valve ablation or the trans-aortic valve replacement. So this is performed via the transfemoral route with a procedure success rate exceeding about 90%. For the aortic regurgitation, the valve does not close completely, leaking the blood back to the left ventricle. These are the etiology of aortic regurgitation. It can be a valvular or problem with the aortic root. Okay. For patients with a congenital bicuspid aortic valve, infective endocarditis, sometimes they could manifest with a perforations or abnormal indentation. For patients with a rheumatic heart, the commissural fusion can cause aortic regurgitation. For patients with systemic hypertension and Marfan syndrome, they can have a dilated aorta, which can also cause prolapse of the cusp. Chylosing spondylitis, trauma, degenerative, or in patients with a ventricular septal defect. Can be seen also in patients with syphilis, rheumatoid arthritis, or in patients with a discrete subaortic stenosis. Rheumatic in origin is much less common in patients with isolated aortic regurgitation who do not have associated rheumatic mitral valve disease. So frequently, aortic has a concomitant mitral valve disease. Patients with congenital bicuspid aortic valve may develop predominant aortic regurgitation, and approximately 20% of patients will require aortic valve surgery. So this is a cardiac magnetic resonance imaging of patients with bicuspid aortic valve, accompanied with the severe aortic regurgitation and ascending aorta dilation. The aortic regurgitation may also result from the infective endocarditis or myxomatous aortic valve. For patients with a primary aortic root disease, this is the aortic root and this is the aortic valve. This can also cause aortic regurgitation. This is an example of patients with an annulo-aortic ectasia showing a central regurgitant orifice. The pathophysiology of aortic regurgitation. The regurgitation results in an increased left ventricular volume, increased stroke volume, and increased aortic pressure. The increased LV volume, which may lead to increased LV mass and lead to left ventricular dysfunction and failure. The increased LV stroke volume increases the systolic pressure and prolongation of left ventricular ejection time. The increased LV systolic pressure results in a decrease in diastolic time. The decreased diastolic time, which is the myocardial perfusion time, diastolic aortic pressure, and effective stroke volume leads to reduced myocardial oxygen supply, which produces a myocardial ischemia, which further impairs the left ventricular function. The total stroke volume ejected by left ventricle is increased in patients with aortic regurgitation. In patients with severe AR, the volume of regurgitant flow may equal the effective forward stroke volume. In the AR, the entire left ventricular stroke volume is ejected into the high pressure aorta. Increase the LV and diastolic volume, or the increased preload, constitutes the major hemodynamic compensation for aortic regurgitation. The LV preload and the afterload are both increased. The deterioration of LV function precedes the development of symptoms. As you can see, there is a considerable thickening of the left ventricle. Autopsy of the hearts of this patient may be among the largest encountered, sometimes weighing of more than 1,000 grams. Three-fourths of patients with pure or predominant valvular AR are men. Women predominate among patients with primary valvular AR who have associated rheumatic mitral valve disease. For the causes of acute severe AR, this includes effective endocarditis, aortic dissection, and trauma. The left ventricle cannot dilate sufficiently to maintain stroke volume. The LV diastolic pressure rises rapidly with association of marked elevation of LA and PA wedge pressure. For patients with chronic severe AR, they have long latent period which remains relatively asymptomatic for as long as 10 to 15 years. Physical findings includes jarring of entire body, bobbing motion of the head with each systole can be appreciated, abrupt distension and collapse of larger arteries. The examination should be directed towards the detection of the conditions predisposing to the AR. Includes the bicuspid valve, endocarditis, Marfan Syndrome, and ankylosing spondylitis. These are the features of Marfan Syndrome, including the positive for wrist sign. These are the features of ankylosing spondylitis. These are also predisposed to aortic regurgitation. For the arterial pulse, they can have a Corrigan's pulse, which is described as rapidly rising water hammer pulse, which collapses suddenly as arterial pressure falls rapidly during late systole and diastole. Quincke's pulse is a capillary pulsation with an alternate flashing and paling of the skin at the root of the nail while pressure is applied to the tip of the nail. Throbb's sign is a booming pistol-shot sound that can be heard over the femoral arteries, and the Dorothy sign is that to and fro murmur that is audible if the femoral artery is slightly compressed with the stethoscope. This is an example of patient with a Corrigan's pulse. And this one is an example of Quincke's pulse. The arterial pressure, pulse pressure in patients with aortic stenosis is widened as a result of both systolic. The arterial pulse pressure is widened in patients with aortic regurgitation as a result of both systolic hypertension and a lowering of diastolic pressure. Left ventricular impulse is heaving and displaced laterally and inferiorly. The diastolic trill may be palpable along the left sternal border in a thin-chested individuals. Prominent systolic trill may be palpable in the suprasternal notch and transmitted upward along the carotid arteries. So in patients with severe AR, the aortic valve closure sound is usually absent. In patients with bicuspid aortic valve, the patient can have a systolic ejection sound and occasionally a fourth heart sound. In patients with chronic aortic regurgitation, they are frequently described as high-pitched, blowing, decrescendo diastolic murmur that is heard best in the third intercostal space along left sternal border. This is how aortic regurgitation sounds. Blowing decrescendo murmur. For mild aortic regurgitation, the murmur is brief. The mid-systolic ejection murmur is frequently audible in patients with isolated AR. These are heard best at the base of the heart. Sometimes patients can have a Austen Flint murmur. The Austen Flint murmur is a soft, low-pitched, rumbling mid to late diastolic murmur. As you can see, this is probably produced by the diastolic displacement of the anterior leaflet of the mitral valve by aortic regurgitation stream. So you can see this is the left atrium. On this part is the anterior mitral valve leaflet. So this is the aortic valve, and this is the aortic regurgitation stream. So it hits the anterior mitral valve leaflet, causing a functional mitral stenosis. For laboratory, they can have a left ventricular hypertrophy with a strain pattern. As you can see in this slide. For chest X-ray, the apex is displayed downward and to the left in the frontal projection. And the left anterior oblique and lateral projections, the LV is displaced posteriorly. For aorta may fill the retrosternal space in lateral view and for patients with aneurysmal dilation of the aorta. This is an example of patient with left ventricular enlargement. For the echo, the LV size is increased in chronic aortic regurgitation. The characteristic finding is a rapid movement of the aortic valve with high frequency diastolic fluttering of the anterior mitral leaflet produced by the impact of the regurgitant jet. For patients with severe AR, the central jet width exceeds more than 65% of left ventricular outflow tract. Regurgitant volume is 60 ml per beat. Regurgitant fraction is about 50% with a diastolic flow reversal and proximal descending aorta. This is how it is computed. Compute for the aortic regurgitant jet in comparison with the left ventricular outflow tract. You can further identify the severity of aortic regurgitation based on the pressure half time. And you can also identify the regurgitant volume. It can tell you if the AR is mild, moderate, or severe. Sometimes on echo, you can visualize presence of vegetations in patients with infective endocarditis that can cause aortic regurgitation, and also evidence of dilated aortic root, which is an example in patients with a Marfan Syndrome. Aortic root dissection sometimes can also cause new onset aortic regurgitation. Hemodynamics in severe aortic regurgitation, there is a simultaneous aortic and left ventricular pressure in patients with a severe aortic regurgitation. Note there is a wide pulse pressure. This is 140 and this is 60 millimeters mercury. For the management of aortic regurgitation, frequently if the patients are severe and symptomatic AR with a LV ejection fraction less than 60%, they are advised for aortic valve replacement. It can be as low as 2.3% in isolated aortic valve replacement and as high as 8.8% with a concomitant mitral valve replacement. For patients with aortic regurgitation caused by aortic root dilation, the remodeling of aortic root with replacement of 3 aortic sinuses can be done. Now we discuss the tricuspid and pulmonic valve diseases. For tricuspid stenosis, This is a obstruction of flow from left atrium towards right from right atrium towards the right ventricle. These are less prevalent than mitral stenosis and generally rheumatic in origin and more common in women than men. It does not occur as an isolated lesion, and this is usually associated with mitral stenosis. For hemodynamically significant tricuspid stenosis, this occurs in about 5 to 10% of patients with severe MS. And sometimes these are usually associated with tricuspid regurgitation. These are either rheumatic or a congenital in origin. So there is a diastolic pressure gradient between the right atrium and right ventricle, and there is a augmented when the transvalvular blood flow increases during inspiration and declines during expiration. In patients with sinus rhythm, they can manifest with a wave and a prolonged Y descent. The cardiac output is usually depressed and fails to rise during the exercise. The presence of tricuspid stenosis can be masked the hemodynamic and clinical features of associated mitral stenosis. This is the summary of clinical and laboratory features in patients with the tricuspid stenosis. The development of mitral stenosis generally precedes that of the tricuspid stenosis, which consists of pulmonary congestion and fatigue. Patients with severe TS can complain of hepatomegaly, ascites, edema, and fatigue. Tricuspid stenosis may be suspected for the first time when the symptoms of right heart failure persist after the balloon of mitral valve. So TS usually occurs in the presence of other valvular disease, and this may be missed unless it is considered. These are the physical findings on patients with severe TS, more of a right-sided heart failure symptoms. Congestive hepatomegaly, giant A waves, or in slow Y descent. The opening snap of the tricuspid valve may rarely be heard approximately 0.06 seconds after the pulmonary valve closure. These are best heard at the left lower sternal border and sometimes over the xiphoid passes. These are augmented during inspiration. Ecg features includes RA enlargement and if patient has evidence of right ventricular hypertrophy, you should suggest presence of mitral stenosis with the tricuspid valve disease. So this is an evidence of right atrial enlargement, which consists of a peak P wave of more than 2.5 millimeters. If the patient has associated mitral stenosis and there is a right ventricular hypertrophy, you would think of possible coexistence of mitral stenosis and tricuspid stenosis. The chest X-ray in patients with combined TS and MS includes prominence of RA, SBC without much enlargement of pulmonary artery. Right atrial enlargement is evidenced by lateral bulging of the right heart border and elongation of right heart border more than 50% of mediastinal cardiovascular shadow. Echo usually shows a thickened tricuspid valve that domes in diastole. Severe TS if the valve area is less than 1 cm squared and a pressure half time of more than 190 centimeters per second. So the echo can also identify presence of mitral valve structure function, the LV and right ventricular size, and the PA pressure. The cardiac catheterization is not routinely necessary. So in patients with the tricuspid stenosis secondary to carcinoid disease, they are usually described as a drumstick leaflets that are thickened, retracted, and relatively fixed. For patients with the rheumatic uh, tricuspid stenosis, the leaflets are thickened with a commissural fusion and a diastolic doming motion. This is a patient with the tricuspid stenosis with concomitant mitral stenosis. We can compute for the valve area based on the mean gradient at the uh, tricuspid valve area. Treatment includes salt restriction, bed rest, and diuretic therapy. In patient who will undergo patient for surgery, patient for concomitant mitral valve replacement. This is also indicated in patients with a moderate or severe tricuspid stenosis or a tricuspid valve orifice of less than 1.5 centimeters squared. Mechanical valves in tricuspid position are more prone to thromboembolic complications than in other positions. The percutaneous valvuloplasty for isolated severe TS without significant TR is very rarely performed. For tricuspid regurgitation, there is a leak of blood from the tricuspid valve. So there is a backflow of blood from right ventricle towards the right atrium. These are the etiology of tricuspid regurgitation. It can be primary, or organic, which involves the valve, or the lower structures, or secondary or functional. Secondary TR due to marked dilation of tricuspid annulus from RV enlargement or due to pulmonary hypertension is about 80% of cases. Functional TR may complicate RV enlargement of any cause. These are commonly seen in late stage heart failure. The incompetent tricuspid valve allows the blood to flow backwards from right ventricle into the RA. The severity and physical signs of TR can vary as a function of PA systolic pressure, dimension of tricuspid valve annulus, and the respiratory cycle. The RB feeling is increased during inspiration. So in a patient with a significant tricuspid regurgitation, they can develop right atrial enlargement or elevation of right atrial pressure, elevation of JBP, including the prominent P waves, or presence of CB waves, which we call the ventricularization or RA waveform. So this is also characterized by RB dilation, systolic dysfunction, pulmonary hypertension, and myocardial fibrosis from previous injury. For mild to moderate uh, tricuspid stenosis regurgitation, they are usually well tolerated. But in severe tricuspid regurgitation, they can have a reduced forward cardiac output. For once the disease progresses and the RV function declines, they can present with abdominal cervical pulsations, abdominal fullness, bloating, diminished appetite, muscle wasting, progressive weight gain, and painful swelling of the lower extremities. The neck veins in patients with severe TR includes the prominent CP waves and a rapid Y descent in the absence of tricuspid stenosis. They are more often diagnosed by examination of the neck veins than by auscultation of the heart. This is an example of a giant CB waves. Other PE findings include marked hepatomegaly, systolic pulsation at the abdominal area, ascites, pleural effusion, edema, a positive hepatojugular reflux, and a prominent RV pulsation along the left parasternal region. Patient can manifest with the Carvalho sign. This is described as a blowing, increase of holosystolic murmur during inspiration. So during inspiration, the murmur increases and then returns to normal during expiration. Okay, so it may sometimes be confused with that mitral regurgitation unless attention is paid to its variation during respiratory cycle and the extent of right ventricular enlargement. AF is usually present in chronic disease. On ECG, look for evidence on inferior Q-wave MI, which may involve the right ventricular wall, and in patients with Epstein's anomaly, presence of right bundle branch block pattern, presence of right atrial enlargement, and presence of atrial fibrillation. Frequently, in patients with tricuspid stenosis, they manifest with a peak P wave at the leads to exceeding more than 2.5 millimeters. For chest X-ray may show right atrial and right ventricular enlargement. For the transthoracic echo, this is a definitive test for demonstration of RA dilation and RB volume. The diagnosis and assessment of tricuspid regurgitation can be made by color flow Doppler imaging. This is an example of identifying the flow. Ay, ano mo na lang. Sige, okay lang. In patients with carcinoid syndrome, this is a characteristic of mobility of tricuspid valve leaflets with a wide open tricuspid regurgitation. You can identify the right ventricle if it is a normal size, moderately sized, or severely dilated right ventricle. And you can also identify the severity based on the hollow flow jet area. And the abnormal color continuous wave Doppler, you can also identify if it is mild, moderate, or severe. Frequently, the Doppler flow in patients with tricuspid regurgitation has a darker shape. Treatment includes diuretics, aldosterone antagonists. For patients with severe TR or who are undergoing left-sided valve surgery, the tricuspid valve surgery can be also performed, especially in patients with a dilated tricuspid valve annulus. This is the summary of treatment patient with the tricuspid valve regurgitation. Now we'll come to the pulmonic stenosis. Pulmonic stenosis is usually a congenital disorder. Valve is typically dome, especially in patients with isolated pulmonary stenosis. The valve can be dysplastic in patients with Noonan syndrome. The less common etiologies includes carcinoid, obstructing tumors, and bulky vegetations. The pulmonic valve is only very rarely affected by the rheumatic process. This is an example in patient with a pulmonic stenosis. This is congenital. Complete atresia of pulmonic valve, or in patient with a bicuspid pulmonary valve. Pulmonic stenosis is defined hemodynamically by a systolic pressure gradient between the right ventricle and the main pulmonary artery. The right ventricular hypertrophy develops as a consequence of sustained obstruction to the right ventricular outflow, and systolic ejection is prolonged. The RV dysfunction from afterload mismatch occurs earlier in the course of pulmonary stenosis and at the lower peak systolic pressures because the right ventricle adapts less well to this type of hemodynamic burden. So severe pulmonary stenosis is described with a peak systolic gradient across the pulmonic valve of more than 50 millimeters mercury. Prominent RAA wave and prominent V wave signifies functional tricuspid regurgitation from right ventricular and annular dilation. For patients with a mild to moderate PS, they can frequently are asymptomatic, and in patients with severe pulmonary stenosis, they can present with exertional dyspnea, early onset fatigue, and anginal chest pain. The murmur of mild or moderate PS are mid-systolic in timing, with the crescendo and decrescendo in configuration, heard best at the left second intercostal space, introduced by an ejection click in the younger adults. This is the only right-sided acoustic event that decreases in intensity with inspiration. Patient can also present with a prominent A wave, which signifies a higher atrial pressure necessary to fill the non-compliant right ventricle. Signs of right heart failure may appear, like the hepatomegaly, ascites, and edema. The ECG can present with a right axis deviation, right ventricular hypertrophy. As you can see, there is a prominent R wave on the B1, and also includes right atrial enlargement. Chest X-ray shows a post-stenotic dilation of main pulmonary artery with a filling of retrosternal space due to right ventricular enlargement. The cardiac apex appears to be lifted off the left hemidiaphragm, and sometimes that RA can be enlarged. The transthoracic echo allows definitive diagnosis and characterization in most cases, with depiction of the valve, assessment of gradient, RV function, and VA pressure. It can also be useful in delineation of RV outflow tract and assessment of hypertrophy. This is an example of echo in a patient with a pulmonary stenosis demonstrating a systolic doming of the congenitally stenotic pulmonary valve. In real time, the valve has a jump rope appearance. This is a color Doppler flow at the pulmonic valve area. As you can see, there is a turbulent flow across the pulmonary valve. You can also measure the peak gradient along the pulmonic valve area. For treatment includes diuretics for patients with symptoms of right-sided heart failure. Treatment includes also the pulmonic balloon valvotomy for patients who are symptomatic with a peak gradient of more than 50 millimeters mercury or a mean gradient of more than 30 millimeters mercury. Surgery may be required when the valve is dysplastic. This is how it looks on a cath lab. This is the pulmonic valve, and this is after the dilation. This is the simultaneous measurement of the right ventricular pressure and the pulmonary artery pressure in patients with severe aortic stenosis. The upstroke of pulmonary artery tracing is delayed, consistent with the pulmonic valve stenosis. For pulmonic regurgitation, there is a leak of blood from the pulmonary artery going back to the right ventricle. These are the etiology for pulmonic regurgitation, and frequently a consequence of pulmonary valve pathology. Can be also due to annular enlargement or their combination. Can also happen in patients with who underwent pulmonary balloon valvotomy, carcinoid disease, and in patients with severe pulmonary hypertension. This results in RV enlargement and eccentric hypertrophy, aortic pulmonary regurgitation. Symptoms include a picture of a patient with pulmonary hypertension, which includes fatigue, exertional dyspnea, abdominal fullness, bloating, and lower extremity swelling. The Graham-Still murmur is the hallmark of pulmonic regurgitation, described as a high-pitched decrescendo murmur, which is heard best at the left sternal border. ECG may show right ventricular hypertrophy and right atrial enlargement. X-ray may show RB and RA enlargement. For the echo, it can show you the pulmonic valve morphology and estimate the PA systolic pressure. This is the best view for the pulmonary valve. You can see there is a pulmonic regurgitation, and you can measure, identify the severity of pulmonic regurgitation based on the anatomy of the pulmonic valve, RV size, and the jet size. This also include the parameters for the jet density across the pulmonic valve. You can also measure the main pulmonary artery and note also for presence of pulmonary artery dilation, which can cause pulmonic regurgitation. For the therapy, includes the vasodilator therapy, diuretics, and patient surgery can be advised depending on the cause of pulmonary arterial hypertension. Surgical valve replacement for primary severe pulmonic valve disease such as carcinoid or endocarditis is rarely undertaken. The transcatheter pulmonary valve replacement has been successfully performed. Thank you.